Welcome back, everybody, from our final break of the day. We do hope it was restful. We are here for our final session titled The Surgical Management of Colorectal Peritoneal Metastases, and we are joined by Dr. Gregory Knapp. Dr. Knapp is a surgical oncologist and assistant professor of surgery at Dalhousie University. He obtained an MD from McMaster University and a Master of Science in International Health Policy from the London School of Economics. He completed his residency in general surgery at Dalhousie University and fellowship training in global oncology and surgical oncology at Memorial Sloan Kettering Cancer Center and the University of Calgary. His clinical practice is focused on breast cancer and advanced GI malignancies. He is a director of Global Surgery Office at Dalhousie University and a member of the African Research Group for Oncology. He is the co-chair of the breast cancer site team within Cancer Care Nova Scotia and the program director of the Peritoneal Oncology Fellowship at the QE Health Center, Health Sciences Center. Thank you so much for being here with us, Dr. Knapp, and I'm happy to pass you the floor.
Wonderful. Thanks for the introduction. I'll pull up my slide here. Great. You guys are seeing that title page? Perfect. Okay. My only disclosure is I do some teaching and some mentorship with Stryker in the breast cancer space. So just in terms of setting the stage, carcinomatosis is probably more common than you think. Depending on the presentation of colon cancer, it can be the second or the third most common site. So it really all depends on the series that you're looking at. Certainly if you have someone with a full thickness, a perforated and obstructing colon cancer, the risk of having seeding of the peritoneal cavity, which again, I apologize, I don't have a great sense of the background knowledge of the group, but the peritoneal cavity, being, we would consider that to be a separate organ site. It's got a function, and it plays an important role in gut mobility and inflammation and immunity. And it's actually a fairly complex, although pretty nondescript looking organ, but it's that slippery sac in the abdominal cavity. Cancer can arise from that. Mesothelioma, very rare, but much more commonly, cancer will spread to the peritoneal cavity in women from the ovaries, and men and women from the colon, the rectum, and the appendix. The historical management is interesting. You can, the not so long ago, it was really felt to be purely palliative, and had really very poor outcomes. These are, depending on how far back you go, these are obviously, it's literature that's skewed by very advanced presentation. But best supportive care from, old literature. So again, take that as a very advanced disease, maybe 6 months. That's with no chemotherapy, just kind of purely supportive. Early innovation was with the introduction of 5-fluorouracil, the modified Loffman protocol, weekly for 24 weeks or until progression, doubled that survival to 12 months. So we'll get patients out to a year. But there's no doubt that patients with disease that spreads to the peritoneum do worse than patients that have isolated disease that spreads to the liver or the lungs. And you can see that on the right side here. So patients with peritoneal metastases, they're Kaplan-Meier, there's space between them and the others. And those that have both liver and peritoneum are going to do worse still. So this is kind of this is a bad acting group, if you will. And I don't get into it a lot in this presentation, but there's almost certainly a unique biology of the cancers that have a specific, tropism or, pattern of spread to the peritoneum. those in particular are the ones that say have more advanced tumors with no nodal disease, but for some reason, big, bulky T4 never developed the ability to go to lymph nodes, but went to the peritoneum. There's probably a unique biology there that we're just kind of beginning to unpack. Um, I don't touch on a lot here, but I think that there's still a lot of room for improvement. Regardless, though, there's been room for improvement for some time, and the poor outcomes for these patients spurred innovation in the US, in the Netherlands, and France. Um, Japan had been doing research in gastric carcinomatosis for years. Interestingly, some of the initial research, came out of gastric ovarian mesothelioma, um, and in the U.S., the procedure that we perform, cytoreductive surgery plus a hot chemotherapy or a hyperthermic intraperitoneal chemotherapy, is still, informally or colloquially referred to as a sugar baker procedure, which you may have heard referenced. Certainly in North America, Dr. Sugarbaker very much a kind of a pioneer in the management of this, both in its form, um, colorectal specific, but then also the low grade form that we see that arises from the appendix. That's actually a completely different beast that I'm not going to speak on today. Um, um, but an innovator in both spaces where there is some overlap. So just to lay the scene, if that's the epidemiology, can be fairly common, up to a quarter of patients with large, bulky, or perforated tumors. I've already mentioned this concept of hyperthermic intraperitoneal chemo. So basically, when the abdomen is open, the tumor removed, the delivery, if you will, of a very high dose chemotherapy mixed with several liters of solution that then circulates through the abdomen. Like, what is that all about? The pharmacokinetic rationale is fairly compelling. There's a large space here. There is a barrier between the what we can deliver in this cavity and what will diffuse across into the blood. We can measure that gradient as an area under the curve, and it allows us to deliver very high doses of drugs safely in a way that we could never do systemically. What makes a good agent? Large molecular weight, hydrophilic, so we can mix it with sterile water or saline. Non-cell cycle dependent. So, 5-fluorouracil, many of our agents require incorporation into the cell cycle for them to be effective. It doesn't work when something's given as a one-off agent. So this is given in the operating room once the disease has been removed as a single time point. So it's got to be cytotoxic regardless of cell cycle, and then compatible with other drugs, and then rapidly cleared if it does enter systemic circulation. The backbone drug that most of us use in North America is mitomycin. This drug's been around for ages. It's got a large molecular weight. It's water soluble. It's non-cell cycle dependent, so it checks all the boxes, and it is rapidly cleared from circulation. And you can see here, an area under the curve. We can generate 10, 20 times perfusion to plasma concentrations. Just in terms of a quick background in terms of where did this come from. Obviously with late stage presentation common last century, and unfortunately still now in many situations, but a huge amount of research to see how we could move the needle on that. Some of the early literature from the 70s and 80s established that you could indeed kill 99.99% of free floating human and animal adenocarcinoma cells with mitomycin, and that heat seemed to potentiate that. And so you can see that here. So with a lower dose, you're getting the same kill. A lot of this was actually used as the kind of foundational basic science research to support the eventual dosing that we still actually use in humans and for the management of this condition now. So you can see here, at 6 micrograms at room temperature, you can half that concentration and still get 99.99% cell kill at 3 micrograms, at least in kind of ex vivo model. I've cut out some slides. I just wanted to paint the picture that there is a body. That's just a teaser. There's a huge body of basic science research from the 60s, 70s, and 80s from around the world that really led up to some of the initial human trials in both France and the Netherlands in the 90s. Interestingly, and I think it helps just provide context for where we are now. Um, you know the French were kind of early out of the gate, and they proposed a trial multi-center that would be systemic therapy versus surgery, so to clear all of that disease in the lining of the abdomen, plus remove the primary if it was still there, followed by systemic. And that would have been the logical study design. Again, up to this point, this was felt to be purely palliative. The only treatment was systemic therapy. The new intervention was really, can we actually remove this disease surgically, right? That would have been the next leap. Unfortunately, they failed to accrue. There was already this understanding that maybe chemotherapy delivered in the intraperitoneal environment would help or would deliver a cure. And so patients were not interested in being randomized to a trial that didn't involve surgery plus or minus the use of this kind of new kid on the block, which was the hot or the room temperature intraperitoneal chemo. So unfortunately, I would say probably the important study didn't happen. A new RCT then proposed after complete cytoreduction, so everyone gets the full surgery to remove all the gross disease, chemo versus no chemo, started. Unfortunately, at least in France, that study also failed to accrue for the same reason. Patients didn't want to be randomized. There was already this, perhaps, provider, but patient and provider, bias, maybe lack of equipoise, that precluded them to complete the trial. What's interesting is you have to take this because obviously it's underpowered and they closed early, but with 35 patients, closed after 4 years, but then data out to 5. These very modest survival curves are superimposed. So it doesn't seem to be a huge difference with the application of that IP chemo. Around this time, the hypothermia really, kind of emerged as maybe one step better than just room temperature. We had some basic science data. I showed that it starts to make its way into prime time, into human studies. Maybe that increases the depth of penetration of the drug. You get this release of heat shock proteins. You're inducing cell damage. If these cells are already defective as cancer cells, maybe that helps clear any microscopic disease that's there, in addition to the actual cytotoxic chemo. So hyperthermia around the same time, again, turn 90s into 2000s, kind of emerges as definitively kind of the new kid on the block for this disease. During this time, and I've mentioned it, we have a bunch of studies, a bunch of research happening simultaneously. But what is emerging is that if you can remove all the gross disease, and so this kind of optimal cytoreduction emerges as a very important theme. And so leaving gross disease that you can see as the surgeon in the peritoneal cavity, and then hoping that the chemotherapy wash is going to kill those plaques or that disease, is quite quickly debunked. And that rendering the abdominal cavity free of visible disease, with the assumption that if there's cells that remain that we can't see or detect, that the chemotherapy, single dose in the peritoneal cavity will kill those cells. The optimal site of reduction definitely emerges as a signal in the early 2000s and definitely persists and is still kind of a key piece of the management today. And you can kind of see that here. The patients with the complete site of reduction, fairly impressive overall survival, especially compared to that historical data I showed um, with really no long-term survivors, median overall survival of 12 months. Now we're looking at three-year, disease-free of 50%. Again, that's a heavily selected cohort. Again, as I mentioned, multiple different groups around the world kind of tackling this problem simultaneously. As I mentioned, the French were struggling to accrue due to a lack of equipoise, but they didn't have the same trouble in the Netherlands, and so they were able to accrue a major randomized trial with patients in a systemic therapy alone arm versus those undergoing surgery. So cytoreduction plus the hot chemotherapy. They were using 90 minutes of mitomycin C once they felt they had optimally removed the gross disease. And those patients in that intervention arm were also getting systemic therapy, mostly after. This was the first, phase. This was the first RCT to reach full recruitment. It was multi-center. Interestingly, they did include patients with both appendix in there, so appendix adenocarcinoma. That was and still is one of the criticisms of the study of many, because the appendix adenocarcinomas do tend to have a better prognosis. So they weren't controlled. The two groups weren't stratified for appendix. And the nomenclature around appendix adenocarcinoma has also changed quite a fair bit since the early 2000s. So we would never see, or we would not say never, but we're unlikely to see a trial where we would put all these pathologies into one bucket again. Interestingly, they did not have a cutoff for optimal cytoreduction or burden of disease, and I'll come back to why that may be relevant. The goal was just optimal cytoreduction, which was defined, fairly generously. Patients were not excluded if they had visible gross disease remaining. The HIPEC protocol derived from a little bit of that literature I demonstrated or tried to show earlier. 90 minutes though of the mitomycin C, basically at 41 degrees, quite a high dose, and then the goal was to get them onto systemic therapy, the same as in the other arm. And what this study showed, and this was this was definitely a game changer, because this was now level 1 evidence that said, listen, a median survival can double from 12 to 22 months if we provide surgery plus or minus, in this case plus the hot chemotherapy wash. And so this basically established the role for surgery and HIPEC, and specifically 90 minutes of mitomycin C, as a key treatment tool for this disease. In the sub-analysis, you can see some interesting trends emerge from this data. So with the completeness of the surgery was really important. If they left gross disease behind, this is a pretty crummy looking survival curve, right? So leaving more than 2.5 millimeter plaques, you were probably not doing. Look at this. 12 months from randomization. These numbers are almost tailing off. You're probably not delivering any benefit over palliative chemotherapy alone. Versus if you're able to render them no residual disease, a lot of space between these curves. Over here, they weren't using what we now use as kind of the standard way of understanding and quantifying the burden of disease, which is the peritoneal cancer index. And it's basically the language that I would say all peritoneal surgeons around the world are now using as a language to define the burden within the 9 quadrants of the abdomen and the 4 segments of the small bowel. But this was another way of capturing that. And you can see if they had lower volume disease, they did better. As I've alluded to, that sub-analysis gave us, a signal that the completeness of cytoreduction and the burden of disease are important prognostic variables. You can see it here as well. They're not the only ones, right? So in terms of how do we now select for patients, that may come up in maybe the question, like the Q&A later. I think we take all this into account. The patients that have high grade, very aggressive looking disease in terms of grade or presence of signet cells, high burden of lymph node disease, which would suggest, perhaps that they are moving towards more of a lymph node tropic, maybe more of a kind of a systemic failure pattern versus the patients that don't. They're going to do worse. And you can see that here in terms of in this multivariate analysis I've just pulled out of a nice paper from the French. But certainly, the peritoneal cancer index, that's the burden, highly prognostic, as was the completeness of surgery. We're aiming to leave no gross disease when we do this surgery now. And you can see this here, survival curves, similar to before. Gross disease, I think we're probably not doing, not probably, if we're leaving gross disease behind, we're not improving survival any more than palliative chemo alone. If we can get it so that there's absolutely no gross disease on very detailed inspection, those are the patients we're trying to select for. And I think more, in addition to that, we're trying to also select for the patients with the low volume disease. So here you can see, this is quite striking. If you have a PCI of greater than 20 and over, there's probably no long-term survivors in most of the data. The French, the American, most of the large series would suggest that. Maybe there's a gray zone between 20 and 24, but it's pretty obvious here. And this is probably, even though it's 2010, up until very recently, the largest series we have with over 500 patients, with very detailed data from high volume centers. But what you can see is that they've got low volume disease here defined as, a PCI of 6 and under. You're seeing a tail to this survival curve that looks like it's close to 50% at 5 years. And so those are numbers most patients can get behind, even if there's a significant short-term hit to their quality of life. I mentioned histology. It's critical. So we're looking at a few things, obviously. I'm not going to go through all of those, variables, but I think the big ones are also around histology. So signet ring cell. These are tiny numbers and small series, but these patients, you can see median overall survivals poor, 5-year overall survival. Most of these series not reaching that point. Okay, so I think we don't fully understand, but it's a different biology. It's a different cancer. What's still yet to be unpacked is the impact of some of the molecular signatures that we have now come into prime time. Here I've just shown some data around BRAF specifically. So we know that the BRAF mutated patients are going to do worse. They seem to be bad actors in the metastatic setting. The initial data out of Sweden showed no long-term survivors. That was pretty stark. Then we get some conflicting data from Norway. So I would say, as far as I know, and at the most recent kind of World Congress, there were very few, if any, centers that were using, say, a single data point like BRAF mutation as an absolute exclusion criteria. I think we're still taking that into the full picture. There isn't kind of one molecular signature that yet has that's risen to the top. Sorry, I should have clicked through there. What I do use to help inform the patient decision making in the conversation, because I think these are conversations. There's a lot to unpack, and this surgery, which can sometimes require multi-visceral resections, which can sometimes require total colectomies, depending on the burden of disease, can easily take us, 8, 10, 12 hours. There's a huge short-term hit to quality of life. There's a fairly prolonged hospital stay. And so patient selection is so important, and in kind of creating the right, the realistic set of expectations around what to expect at month one, at month three, at month six, I think is critical, in addition to the survival piece. I use the compass nomogram as part of that conversation. This is really helpful if the tumor is already out. So they've already had their right hemicolectomy. We know the nodal status, and then they've presented with carcinomatosis, say 12 months or 18 months after surgery. And so we look at age, PCI, nodal status. You can see how important the signet ring cell histology is. And then it gives us fairly granular 1, 2, and 3 year overall survival numbers. You've heard me, speak of, PCI. Again, PCI is just, the acronym for the burden of disease. The trouble with it and the why, I've mentioned a couple different numbers. Is it 20? Is it 24? Here I've got 17. It's because there's no clear inflection point. So it's fairly linear, the relationship between PCI and survival. When you really dig into the literature, probably one of the most elegant ways of visualizing it is this this nice graph here, which shows you that basically at 17, the hazard ratio, crosses, the confidence interval crosses 1, right? And so you're like, okay, you know, you know, treatment effect could be due to chance here. As we get clearly north of 20, right, and before we get to 25, we're at 1, right? And so I think that there's zero doubt that no one is offering cytoreduction and HIPEC for folks with colon cancer. So an adenocarcinoma of the colon or rectum with a burden greater than like 25 and greater. At our center, we've got a fairly hard cutoff of 20. The gray zone we basically reserve for the appendix adenocarcinomas. And many French centers use 17 as a hard cutoff. So, what does PCI actually reflect? This is something that we can get philosophical on. But to me, what I think when you look at it somewhat objectively, why does that matter? Like if we can render, like if we think that the hot chemotherapy wash is going in and is killing any, free floating cells, then if you can get it down to nothing visible and it's just microscopic, well, like why does burden matter? And I think it's one of the signals that we're going to see emerge, with some new data that's coming in the next couple of years that I think is going to question the actual role of the hot chemotherapy wash. I think the low volume disease are the patients where, yes, it has spread to the peritoneum, but with an aggressive peritonectomy, you're actually removing all of the disease, even microscopically, right? And the high burden of disease, I think, reflects that there is microscopic disease remaining in the peritoneum, and that's not effectively, we know systemic therapy doesn't penetrate well, and that the hot chemotherapy wash maybe isn't as effective as we think. It could also be that larger PCI also just denotes a different biology. You're going to have, tumors where you've got a big bulky tumor with it, with cells that are truly kind of sloughing off because the cancer is so bulky, versus a much smaller cancer that for some reason those cells develop the machinery to spread, via the peritoneum versus via the nodes early. And perhaps that's just actually a different beast altogether. With all that surgery talk, there's been a huge improvement over that kind of 20-year, historical run, in systemic therapy, and we know we're getting way better outcomes with systemic therapy alone. If we pull out, the real, the true stars, those are our, KRAS, BRAF, wild type left-sided tumors, where we're now getting, median overall survivals like north of, well north of 2.5 years, 30 months, 36 months. it's kind of, you can see that right here, data publication, median overall survival for metastatic, previously untreated colon cancer improving over um, um, over that 10-year period. And I think, most people would agree that's their lived experience in practice. The most recent and really the only second fully published randomized trial in this space is the PRODIGE 7 trial, which took patients much more heavily selected. So they had to have a PCI less than 25. They all got 6 months of modern perioperative systemic therapy. So the old Dutch Verwaal trial, some of them got just 5-fluorouracil. At the end of the trial, they were getting, FOLFOX or FOLFIRI. All these patients were getting kind of modern, doublet or triplet therapy. They all got, standardized surgery at a high volume center with complete cytoreduction, then were randomized if they could achieve a complete cytoreduction to the HIPEC versus no HIPEC. Somewhat unfortunately, they basically randomized to a protocol that wasn't very commonly used in North America. So that was oxaliplatin for a short duration. But what it did show was that there was no difference in survival. So these are again all patients that got complete cytoreduction, but the addition of the HIPEC, so that hot chemotherapy wash, at least as defined by 30 minutes of oxaliplatin, did not improve um, um, progression-free or overall survival. But these numbers were, I think, what's striking though is that we had never seen in a randomized, prospective fashion a median overall survival for this disease state of 41 months, right? So, it was that alone was actually a big step from where we thought we could get these patients based off of the literature. Um, and I think this is one of the take homes, is you can see here. So this is the sub analysis broken down by burden of disease. Here they've defined low as less than 11, but look at that. That's a very clear tail. Time months 54, 60, 66 months. That curve is flattening. 50% of patients still alive with the low volume disease. And so I do think, although I use that term, even still cautiously with patients, often because we don't know their true PCI until we're in there. But I do think that we achieve cure. I have in my own practice had patients out to 5 years with low volume disease, where we're pretty happy it's not going to come back. The progression-free survival is a little bit more sobering, but I still think that you can get a quarter of patients, not only alive but alive without disease at 5 years, if it's low volume. What do the guidelines say? So, still, and it's interesting. The guidelines have been slow to or at least as they always are, really, more cautious. And so it's the NCCN states that if an R0, so complete cytoreduction, can be achieved, that you could consider it basically in experienced centers. The Chicago consensus a bit more bullish, but this was a consensus of peritoneal surgeons. So, surprise, surprise, they're in favor of cytoreductive surgery and HIPEC. The ASCO guidelines, they've looked at this, they've looked at the available evidence. The recommendation is that complete cytoreduction plus systemic therapy may be recommended for select patients. The qualifying statement was their take on the PRODIGE 7 data. So, all comers, 15% progression-free survival at 5 years, only should be considered in centers with extensive experience and an MDT. What's some of the controversy? Hopefully you've kind of got a flavor for it, right? But there's definitely a lack of evidence for the various types of HIPEC. So HIPEC, it's just a route of administration of chemo, right? And so often you'll hear people talk about HIPEC like it's a singular entity, but it's basically like saying systemic therapy, right? It's not singular. How it's delivered, the drug, the dosing, the hyperthermia. Like there's numerous iterations, and unfortunately, we have not been standardized in how it has how these different protocols have been evaluated for efficacy, and that's really hampered, I think, the whole field. Um, early experience did suggest a big bump in complications, because you could say, well, if it's fairly innocuous, like a single one-time delivery, what's the big deal? Just give it to everyone. But the Verwall data did show that there was a 40% grade 3 and 5 complication rate, 8% perioperative mortality. That's mortality, not morbidity, in the group that got the CRS and HIPAC. Now that was the first study. Fast forward 20 years, high volume center, 2 decades more of experience. There was still, a statistically significant difference in the morbidity between the two groups, the group that got the HIPAC and the group that didn't. There's been other RCTs in the ovarian cancer space that showed no difference, but I would say that like the HIPEC is not completely innocuous. It does carry with it, even in my own experience, probably a prolonged hospital stay. You get a bit more ileus. I don't think it's not a completely neutral intervention. And just to that point, I think it does come at a patient and system cost. Controversies in surgery. I think I mentioned this. Modern systemic therapy has improved a lot, right? I don't think I don't think there's equipoise, but you could ask, like, if we had a repeat trial that looked at modern systemic therapy, especially if we pulled out some of the better actors with the higher rates of pathologic complete response. What if we could pull out just the patients that have like the MSI high tumors that can now access immunotherapy? Like, if we could somehow redo those studies, is there still a role for surgery at all? And I think especially in the patients that have, MSI high, are demonstrating, deficient mismatch repair proteins, who have a great response radiographically to immunotherapy. The field doesn't know what to do with those patients. And I've got several who we're just now watching, and who I suspect will never see surgery, which is exciting. So that's obviously where some of the challenges come in, right? The fields are progressing, the surgical literature, the systemic therapy literature, and I think on top of all that, even just our understanding of the disease is changing rapidly in terms of right versus left versus the molecular profile. I think we're all eagerly waiting for a more granular molecular signature, that selects for the patients that are going to benefit from this operation and this approach. Just a quick note on recurrence and outcomes. I've got a few minutes left here, so just to say that I think you can gather from the literature thus far, recurrence unfortunately is still common, perhaps up to 70%, depending on the series. That the time to recurrence, generally around a year and a half, but obviously highly variable. Interestingly, right now, when we look at and how do I counsel patients, I still say that without more molecular information, just all comers, a third are going to recur locally, a third are going to recur within the another site, so liver and lungs, plus the peritoneum, and then a third are going to recur just distantly from the peritoneal cavity, with a fairly even spread. When the well-selected patient, there's quite a fair bit of literature that would support going back for iterative surgery. Again, it's all about patient selection, obviously, but isolated recurrences we can go after, and they do seem to benefit from that. Maybe we're just kicking the can down the road, but if that buys them a year or two off systemic therapy, most patients are pretty keen on that. And again, I think the literature would support benefit. How about just throwing some HIPEC in for those high-risk patients? What's the role for prophylactic surgery, either the site of reduction and or the HIPEC? There's actually, because these studies are actually easier to accrue to, two big randomized trials that have looked at that, COLOPEC and another PRODIGE study. And they took patients, slightly different inclusion, but again, those with the high risk of peritoneal disease, T4, perforated colon cancers at presentation, and then basically, they had kind of an adjuvant, if you will, HIPEC plus or minus the cytoreduction if there was gross disease. Um, that was Colopec, kind of your standard primary endpoints. They showed no difference to that approach. So just those patients that are presenting in an emergency fashion, doing the prophylactic HIPEC at some interval, didn't seem to improve outcomes any more than the control group, which would just have received systemic therapy if they were otherwise eligible with active surveillance. So really no benefit in that group. Again, that was 30 minutes of oxaliplatin. So you could argue, what if they had used 90 minutes of mitomycin C? Like, we don't know. I can tell you there's multiple randomized trials right now accruing various iterations of these questions. Um, so the landscape may still yet change. Profilochip looked at slightly different group. So perforated tumors, but they also took those with low volume disease. This comes up every once in a while. Community surgeon will call me. They started to do like a standard right hemicolectomy, and there's a single little plaque, just adjacent the cecum in the pericolic gutter. Like, what do I do? So that comes up. This group here took those patients and randomized them. They got 6 months of systemic therapy. If there was no radiographic evidence, then they had this, what they called a second look surgery plus HIPEC, again with 30 minutes of oxaliplatin, versus just what would be standard, which would be, these patients had their surgery, complete removal of everything, chemo, and then active surveillance. They also showed that there was no difference in disease-free survival. Interestingly, at that second look, a third of patients had carcinomatosis. So that's, that number was high with a mean PCI of 4. And what's interesting is that, it starts to get messy in terms of the methodology, but, their intention to treat the 5-year disease-free survival, 49 versus 42%. But, almost half of those that had, 22% of those, that ultimately had a recurrence, um, um, did cross over and receive the CRS and HIPEC across both arms. This just goes to highlight that, the second look does come with it a risk of complications, right? 41% in that second look had some complication, not surprisingly, right? They got another laparotomy and a HIPEC versus the patients that just had active surveillance. So it is definitely coming at a cost. But, by the book, this randomized trial with 30 minutes of oxali, this high risk group, if you just wait until that disease recurs radiographically, select those patients and operate on those patients, their survival is no benefit than hitting the whole group prophylactically with something up front. So, in conclusion, I do think that, cytoreductive surgery plus or minus HIPEC is beneficial for the well-selected patient with low volume carcinomatosis. I do think long-term disease-free survival and overall survival in those patients is achievable, and may exceed, quality of life and some hard outcomes, versus even modern systemic therapy alone. I do think cure is possible. I do use that term, cautiously with the right patient, based off some of the data I've presented. There's no benefit for 30 minutes of oxaliplatin, either upfront or prophylactically. North America tended to use the 90 minutes of mitomycin C, and that would still be the most common protocol used in Canada across our peritoneal centers. We need greater standardization. So Canada is no, we're not any better than elsewhere in terms of, still taking a fairly heterogeneous approach to, um, to patient selection, but also to our HIPEC protocols. I'd say it's helped a little bit with the Protease 7 showing no benefit. So basically everyone's migrated at least to the same drug, but the exact dosing, varies by center. So we're using a slightly different dose in Halifax than they do in Calgary, than they do in Toronto, which does even make which makes bringing the data together even challenging. What's the future? We've got upcoming trials that are going to look, basically replicate PRODEACH-7, but with 90 minutes of mitomycin C. Same in the prophylactic setting. The immunotherapy is a total game changer, as I mentioned. We discuss cases on a national level, and most centers across the country right now, if there's a radiographic complete response on immunotherapy for the patients with carcinomatosis, we're not going in and just excising scar and high pecking, so they're being observed on immunotherapy. So I've got a couple of patients that are now on immunotherapy over 2 years, tolerating incredibly well, and we don't really know when to stop. So we're waiting for a signal, us medical oncology, but that's opened a whole new frontier for a disease that prior to immunotherapy, did even worse than the microsatellite stable group. So that's it. Christopher, are we doing questions now? Are there questions, or how does that work?
Yeah, well, first of all, thank you so much, Dr. Knapp, for being here with us today, but also for this wonderfully informative session on a really, really important metastasis site for some of our metastatic patients. We appreciate your time and expertise very much. Right now, what will happen is our coaches and Dr. Knapp will go and head back stage for the final question period for today. And both Philomena and myself will be here to close out today's agenda for our silent viewers.
Okay.
Thank you, Dr. Knapp. All right, and as we normally do to close out our days, we love to have a quote, and I'm happy to share this quote with you today. Today says, "The human spirit is stronger than anything that can happen to it." And I personally believe that both trust and belief go such a long way in our journeys. And as support providers, we can really instill that trust, building right from the start. So to anyone who's looking for support, our coaches are here. We're ready to support you. Please do reach out absolutely anytime. And now I am happy and honored to pass the screen over to our president and CEO, Filomena Servideo Italiano, to say goodnight to all.
That's great. Thanks very much, Christopher. Thank you, ladies and gentlemen, for having joined us today for what I believe was a fantastic lineup of sessions dedicated to the management of metastatic disease. We certainly have come a long way in managing metastatic colorectal cancer from a systemic point of view, as well as surgically managing peritoneal metastases. A patient's biomarker status is now the standard of care in helping to inform a metastatic cancer patient's treatment plan and should be incorporated into all clinical decision-making processes to ensure optimal outcomes. A special vote of gratitude is extended to our event sponsors, without whom this event would not have come to fruition, namely Natera, Pfizer, Taiho, and Masters Insurance. Thank you for your support. We are appreciative of your dedication to our work. I invite you all, ladies and gentlemen, to participate in tomorrow's sessions that are once again dedicated to addressing the management of metastatic disease. Sessions will focus on the surgical management of colorectal liver metastases, a review of clinical trials, the radiotherapeutic management of metastatic colorectal cancer, the role of ctDNA, minimal residual disease, in delivering personalized cancer care, and using naturopathic medicine to address treatment-induced toxicities. And our very own Christopher Mammoliti will review CRAN's resources and programs to help empower our patient population. So I do hope to see you all tomorrow morning. Until then, I wish you all a very lovely evening. Good night.